बरं, ठीक आहे ना.
अराउंड 45 मिनिट्स आणि नंतर मग आपण थोडं क्वेश्चन आन्सर घेऊयात.
ठीक आहे सर. ओके.
येस सर.
By 4 o'clock we should be
Yeah, we should finish it 1 or 2 minutes before 4.
before 4. ठीक आहे. तर मी एक 45 मिनिटच्या आधीच संपेल मला
हो
वाटतं.
हो. नंतर मला पण एक वोट ऑफ थँक्स द्यायचं.
बरं बरं. त्या दिवशी तुम्हाला भेटून छान वाटलं सर. यू आर
सर सेम हिअर सर. सर आपण आता लाईव्ह आहेत सर ऑनलाईन. वी आर लाईव्ह ऑलरेडी.
ओके.
Welcome, Pro VC sir. Good afternoon.
Welcome, sir.
Dean madam, good afternoon.
सर नमस्कार.
नमस्कार सर. गोडे सर नमस्कार.
नमस्कार. त्या दिवशी आपली भेट नाही झाली सर. मी येऊन गेलो.
हो नेमकं मला याला जावं लागलं मंत्रालयात.
जी.
पळसकर सर माझ्यामध्ये चालू करायला काही हरकत नाही.
Yes,
Oh,
sir.
sir. Yes, sir.
Very good afternoon. On behalf of the academic wing and the University Research Department, as part of the D.S. Aher, Dr. D.S. Aher lecture series, it's a pleasure to welcome our chair professor, Professor Dilip Gode sir, for his talk on challenges for research in tribal area. I have a very long list of CV which sir has given, but have edited a bit, sir, so excuse me for the same. I also welcome our Pro Vice Chancellor, Registrar sir, COE sir, Finance Officer, Law Officer, Deputy Registrars, Assistant Registrars, and all the other people who have joined us online for this very talk from various colleges and of course from all over the university. So Professor Dilip Gode sir, he has his PhD in minimal access surgery. He's done his UG from Nagpur University, PG General Surgery from University of Pune in 1980. Fellow of International College of Surgeons Association of Minimal Access Surgeons of India, Fellow of American College of Surgeons, Honorary Fellow of College of Surgeons of Sri Lanka in 2018. The various posts that have been held by Sir till now are Professor of Surgery, JNMC Savandi Varda, Director, ABBRH DMIMS Savandi Varda, Vice Chancellor DMIMS Savandi Varda, Honorary Professor of Surgery DMIMS, Dean Datta Mege Medical College Nagpur, Dean Dr. Rajendra Kode Medical College Amravati, and as of now, of course, very proud to say, Chair Professor MUHS Regional Center Nagpur, and the Principal Investigator for Blossom Research Project. He has more than 100 national and international research presentations, many publications in national and international journals, and has taken special training for GI endoscopy, laparoscopic surgery, and colorectal surgery. Apart from that, he serves in a lot of social work, conducts advanced laparoscopy workshops, and also has performed more than 10,000 lap tubectomies in rural areas of Maharashtra. So this was just a brief note that I read about Sir, but Sir, I know him personally too, and definitely a very strong role model for all of us. And Sir, we eagerly await your talk on this challenges for research in tribal area, because as we all know, that the tribal population definitely makes up for quite a huge chunk of the entire population of the country. It's just that they are scattered in various areas and that too far off areas. And when we talk of health reaching to the last person in the country, we definitely think of health reaching out to the tribal people. But at the same time, definitely challenges because they are a little rigid in their own lifestyles and beliefs. And that's why probably becomes more difficult and more challenging to get modern healthcare across to these people. And since you've worked at grassroots level with all of them, look forward to your talk, Sir. Over to you.
Thank you very much, Madam. Thank you for so kind words. And thank you very much for giving me this opportunity to present something, I think, which would be beneficial to all those who are trying to think that they would sometime or other times in their career would do something for tribals in our country.
Sir, sorry to interrupt you.
Sir.
I would like to request our Honorable Pro VC Sir to address the gathering, please.
Okay.
Sir, I think after completion of Sir's lecture, I will address it.
Okay, sir. Thank you, sir. Thank you, sir. Sir, please continue.
Sir, yeah, continue, Bode, sir.
So I just would like to introduce few this thing about the realities about what tribals are in our country. Tribal population is basically the poorest and most marginalized group. They have extreme levels of health deprivation. They lag behind the national average on several vital public health indicators, with especially women and children. They are most vulnerable. Their tribal population is total 8.6% of total Indian population as per the 2011 census. And there are about 705 tribal communities in our country. And they have triple burden for this tribal population. That one is communicable diseases are still there, non-communicable diseases are there, and their addictions. So these are the three problems which this tribal community is facing right now. To understand the magnitude of the problem of their health, let us go through some of the health indicators. Now, infant mortality in tribals is about 62.1% as compared to 57%. Neonatal mortality is around same, is 39.9%, but in Gadchiroli, they are really brought down this to almost 20 to 21% because of their surge NGO, which is acting in this field. Postnatal mortality is 22.3% as compared to 18%. And child mortality is 35.8% as compared to national 18.4%. Under 5 mortality is 5.7%. The percentage of institutional deliveries in tribal area is just 17.7% as compared to 38.7%. And very important is percentage of household covered by health scheme or insurance is just 2.6% as compared to 31.9%. And prevalence of anemia is 68.5% as compared to 55.3%. So we can know the magnitude of problems in tribal area about their health if we just go through these indicators. Even their nutritional status. Now, 46% of women, the BMI is less than 18.5. So most of them have malnutrition. 68%, as I already said, are patients, people have anemia. 20% of children have just received vitamin A supplements from 12 to 35 months of age. And if you go up to 5 years, it is just 14.6%. So it is very, very less. And 47% of population is below poverty line, but maybe just 20 or 25% in addition to this 47% would be just marginally above the poverty line. So how could the research help them to alleviate their sufferings or give them a better healthcare? So what we need to do is gather empirical evidence of programs like integrated tribal development. Basically, Government of India and the state government, they have so many programs for the tribal regions. But the only problem is that those programs or the benefits of those programs are still, these people are deprived of. These programs cannot reach the last person in the community. So we also have to see how technology now and social media can alleviate the various problems of their school dropout rate is very high. At the about 4 to 5 standard, they just come out of the school and do some other works. So, but government of Maharashtra has started now these ashram schools, and it is doing a lot of good things in the tribal area. And we must emphasize on tribal medicine research. It is very important because they have so many household medicines and so many, like what we call as jadi booties and all those things, but there is absolutely no research on this. Probably we need to see how we can use these medicines itself to alleviate their healthcare. So the goal ultimately is to improvement in healthcare infrastructure through research and capacity building. Now, what exactly is capacity building is we need to undertake training. Now, as our MUHS, I'm very proud to say that we are going to start this tribal health fellowship programs, fellowship, so that again, itself is a training for the medical staff. We need to provide diagnostic facilities for genetic defect. There are a lot of people who are suffering from anemias, sickle cell disease, thalassemia, all those are genetic this thing, and we need to provide those facilities. We need to treat anemia, we need to treat malnutrition. We need to do a lot of genetic counseling, also marriage counseling. There are a lot of early age marriages are there. We need to have the centers for prenatal diagnosis. So these are very important things. So this should basically be our aim, that through our research, we should try and achieve these objectives of this. Otherwise, there is no point of doing any research if the community is not being benefited. So what is the role of research there? Now, in tribal area, research has to be community-based. We need to see that the entire community is benefited out of our research. So preparing the community for implementation. Now, once you have done a research, we need to implement our finding. It's not that 68% have anemia and we just don't do anything. You sit and tell the world that our tribal people have, what have we done? So we have to try and prepare that community to accept our solution also. That is also very important because they are very reluctant to accept things from our side. So we have to have planning and implementation for community-based studies in tribal areas and steps in implementation of tribal health research and their challenges. The challenges in tribal health research are even at every stage. There is a challenge at planning stage, there is a challenge in implementing the stage and post-implementation stage. So everywhere there are challenges, but we have to take that challenge and see that we do something for the betterment of this community. Now, community-based tribal health research is, what is a community? That's going to be a unit of our study. So tribal people have different set of problems. Now, problem in suppose a village near Nagpur or near Nashik, there will be they have different problems. Like there may be a shortage of drinking water, electricity, something like that. Their water, the hygienic water in tribal area may not be available at all. Electricity may not be there at all. And there is no question of having this internet and all those mobile phones in those areas. So their problems are different. We have to build on the strengths already present in the community. So whatever are the strengths of the community, that should be utilized for our research. We cannot depend on ourselves that from Nagpur or from Nasik, we're going to take certain things there and do that. That won't last long at all. And involvement of local community members and local administrators. Without their help, actually research cannot go about. Collaboration and partnership with communities in all stages of research. So in fact, the tribal community on whom we are going to conduct a research, they are the partners or they are the collaborators in our research. That point we have to, and therefore we need to have a good communication, not that we go to one village, do something and come back and then there is no communication. And then we publish our results after 3 months and then tell us. So those people would not be interested in what we have done. If what we have done, we should see that those things, benefits of those things reach to that community. It has to integrate our knowledge with the action for the betterment of the community. And any research in tribal area or in community-based research, it has to be action focused. It should not be just a result driven, that so many patients are, or so many people are having domiciliary deliveries. There's no point in doing that. We know everyone would know what are their problems. We have to have an action. So what do we do? To have a supervised delivery or to go to a primary health center or sub-center or the IR to be conducting the delivery. So we need to have something, some plan for the action which we are going to take. And if our research is action focused, the community will welcome us. They are very interested in that. So what are, in fact, the pillars of community? Same thing, that community-based, grounded in the needs, issues, concerns, strategies, and communities, and the community-based organization that serve them. Now, what happened? I think majority of you may be knowing Dr. Abhay Bang, who is running a NGO called Search in Gadchiroli. Now, when he went there, he did a research, took blood samples and found out that majority of the people there are suffering from sickle cell anemia. So he called all the people there, had a meeting, and he told those people that, yeah, see, you're all suffering from sickle cell anemia. The public was not interested. The local population said, yes, so many people have told that, but we don't have any problem as such, that we are not sick, we are still working. So basically they were not interested. Dr. Bang told them that we'll now go to government, we'll get some grants for you to give medicines. All. They said, so we have neither asked you to do for us this one, neither we are interested in getting anything like this. So probably what is the need of the community? Community need there was the high infant mortality rate. Then he said, oh yes, we need to do something to bring down the infant mortality rate. So that was the interest of the community. So they all participated in that research. So that is how we have to see how the community-based research goes on. Participatory, like directly engaging communities and community knowledge in the research process. So what he did, he selected people who were at least educated up to 2nd standard, and he taught them how to give an intramuscular injection. And from cleaning, from boiling, from asepsis, and giving it very, very aseptically, that's what he taught those up to maybe 2nd standard to 4th standard, whosoever were available, especially ladies. And then he invited a professor of pediatrics from AIIMS. And he told them, okay, now you see that I have trained these many people. Now you see whether they can really give an injection to these children or these infants. So they said, you have trained it so well that now probably even AIIMS resident, if they ask, probably they would not be available. And he had 19 steps in that SOP how to give an injection. So, and people were really interested because they thought that it's going to bring down the infant mortality rate. So that's how the community participated, community collaborated, community became a part of his research, and that research now, it has been a national model for the infant to reduce the infant mortality rate. So action-based and oriented, as I said, it has to be supporting and or enhancing the strategic action that leads to community transformation and social change. Some research, you do something which is going to transform their life, which is going to make a social change. Now they are, suppose, alcoholic addicts. How you're going to do a de-addiction program that you think. And if you implement that, that's going to change their lifestyle. So participatory research is a framework. So community participation, as I said, to the extent possible, actively engaging community at all steps of the research. Get them in your research. Now, this research basically is a community-based, so it is not a lab-based, or it is not that we collect samples, take them, analyze them. It's not that. So basically, it's there in the community. So participation of the community is very, very important. Then what is your research? Systematically gathering information about an issue and then maximizing the validity. What information you get, that should be validated. And then, of course, the action, or like we have this Blossom project. So there are 3 phases of it. One was to community participation. Now we have collected the data. Now systematically we are going about it, now analyzing that data. And whatever the outcome comes, we are going to have the action for that outcome, that is called service. So first is survey, then solution, and then it will be transformed into service. And that service sector would last for next 3 to 4 years. So that will be the community would be benefited out of this project. And that's why we are getting a good response as far as community is concerned. Now, what are the challenges in the tribal regions? If you have visited, they are geographically remoteness of the village. Now, if I said from Nagpur, it is almost, if I have to go to Hidur, it is about 355 kilometers from Nagpur. So I can't go in day one, conduct a activity there or do my research work and come back. It's not possible. So that is also a challenge. Limited infrastructure. You go to that village, there may be a sub-center. Government of Maharashtra has they have done lot of things as far as the infrastructure is concerned. But that sub-center may not be working. There may not be electricity. There may not be anybody in that sub-center. Then language and cultural barriers. The language is a big barrier in Gadchiroli district. They speak that Gond language. We don't understand. So we need to have someone who knows their language. So we have to depend on either teachers, local teachers, or ASHA workers like that. Then there is scarcity of healthcare professionals. They are not there. Socioeconomic disparities are so much in those tribal areas that we cannot imagine how they wear clothes, what type of clothes they wear, and what we always think about this, and need of cultural sensitivity. We need to respect this. They may not be wearing anything, but we need to look from the angle about whatever they are doing from their point of view. They may be correct. We can't just say you wear jeans from tomorrow. You can't impose anything out of our thoughts. Geographical barriers, as I said, remotely located. There are no roads. Either they are, if there are there, they are inaccessible. In the rainy season, you can't travel. They are almost poor quality. There is a lack of public, private transport and ambulance service. To tell you that in most of the villages, it is such a problem for us that there are no washrooms. Now, if you're going to stay there for at least 10 hours, where are you going to use these facilities? So these are the problems of areas. Now see this, our vehicle got stuck up. So we had to get somewhere tractor from some village which was nearby. So it took about 4 to 5 hours to come. So everything gets, it cannot be time bound that morning we go and evening we come back. So these are the real challenges. Remoteness, as I said, these communities are often located even from their Gadchiroli district headquarters. Their villages are there 250 kilometers, 150 kilometers, which is non-accessible. There are dense forests, mountainous terrace, and there is inadequate transportation infrastructure. So we need to have our own vehicles. That also sometimes because of roads may not reach that village. The unique geographical characteristics of these areas make it difficult to establish and maintain healthcare facilities also, and ensure timely and efficient delivery of medical supplies and services. Now, if the medicines are not there at sub-center, you can't get something in 1 hour time or 2 time. It will take 2 days, 3 days, and within those 2 to 3 days, that sub-center or that PHC would be without medicine. And if there are any emergency, they would simply say that we don't have any facility. You go to that PHC or go to that hospital, and going there itself is a major problem. So tribal, what they would do, they would take the patient to their home and wait. Either the facilities come up or wait till the patient's end comes. So these are the things, very, very tragic thing, very you could see when you are doing this type of research. This in engaging community, as I said, that any research project, we must engage them, we must get them together. So literacy, because illiteracy is there, ignorance is there about their health issues. There are unfelt needs, health is not at all prioritized. They most important probably would be to go to field and get some money out of. So they are very difficult for all of us to see that they are engaged in our research. Lack of human resources. There are no doctors in those areas. Grassroots level workers are not motivated. There may be Asha workers, they are not coming every day. Anganwadi worker, they are not coming every day, and there is no one to supervise. And there is also the hindrance by the activists in some of these areas. These Naxalites and all those movements are going on. So it becomes a hindrance in our research, and that's a big challenge. Sometimes you go there and maybe if you're lucky, 2-3 kilometers away, there may be a bomb blast. Lucky means it is not in that same village. So again, for next 15 days or maybe for 1 month, everything is stopped. So this is a challenge that, and we have to have, that's why we cannot have these deadlines especially in these type of researches. Now let us see the step 1 of planning challenge. So how do we overcome this challenge? Now see, I have always take the help of local administrator, whosoever there may be, maybe a Gram Sevak or some worker who is at least coming there. So you can take the help of that, because that fellow is known to everyone. And once he tells those people there, they would at least for that time, for that sake of time, they would help us in, or they would participate in our research program. Implementing teams has to travel afar for making arrangements. Suppose I have to conduct a camp tomorrow at some village Sode. So it is now again about 250 kilometers. So I have to arrange everything for my team there. That's a big challenge. Suitable location now, if there is a school, well and good. If there is a community hall, that community hall may be there, there may not be electricity. So our BMD machine may not work. And so if there is nothing, then we'll have to put a pendal or something where we can examine the patient. We need to have privacy for patient. See, that is what we have to see, that whatever their status may be, we have to maintain the dignity of the people there. You can't just say that you examine a patient, there is no privacy. You cannot do that. It is not justified at all. Community volunteers, yes, some students can come. Students means suppose some youngster, they can be of help, at least to get people from their houses for examination, all those things. Local leaders, I mean Sarpanch, if that village is big enough, the Sarpanch may be there, so he can be of help. Publicity is to be made through proper channels. Now what proper channels? Only channel there is arranging a Gram Sabha. Now Gram Sabha is arranged because maybe a Gram Sevak will say that tomorrow doctors are going to come, so you have to come yourself. So that awareness is there. And logistics have to be made available for the team. Now logistics are very, very expensive these days. And to travel these distances with our own arranged or private buses, it becomes a lot of problematic things. And more interior you go, more are the problems about your, sometimes that bus will not have a stepney, it will get punctured. Then you take that tire to some neighboring village, go there. 4 to 5 hours are wasted in such type of things. So you have to conduct these type of meetings there. Training sessions at every place, wherever you are trying to take a research project, you must train your team, what they are supposed to do, what ASHA workers are supposed to do, what medical officer is supposed to help you. All training must be there. Then collection of data. So who is going to collect the data? We had employed in our project ASHA workers. And the fact about ASHA workers are they are not salaried people. So they work only on incentives. So they would demand some money. So they used to ask her for 200 rupees per family for per form. So we had to pay. So that is how the things becomes more and more expensive in these areas. Then challenges are also during the training, the language difficulty. If there we have to train the local people there. First is they are not available. If they are available, language is the problem. ASHA workers also, they have to come through a long, though even the distance between two villages is more, and there is no transportation. So they have to come specially by, I think someone would drop them on motorcycle. All those things are there. There are undue delays due to terrain, weather. Repeated retrainings are needed. This is very important, that repeatedly, because what happens, we had done a training in Gondia and we wanted to start this thing after 7 days. But then there was some issue with the medical college. They had some problem. There's some inspection. Then this NMC inspection was there. So Dean would not let them go. So ultimately it was only after 1 month that we had to start. But within that 1 month time, they had forgotten what we had told them. So again, retraining. So again, our team from Nagpur would go there, train them. So this type of, but then unless they are trained, they would not know what is to be done. So repeatedly, we have to arrange this retraining. Then we do not have these logistics. If you have conducted doing some training at some remote place like AV-aids, projectors, then again you have to carry all those things. And the trainees themselves, they are from, say, villages, from community, they may be hesitant to ask difficulty. So you have to ask individually, what are the problems? How will you fill that pro forma? How are you going to take the measurements? All those things then you have to take. So these are some of the volunteers being trained like that. These are our team members. Then community engagement challenge. Again, how do you involve the community? So identify suitable research partners and invite them to collaborate. Now, who are there to collaborate? It is only health department. There is one office of tribal commissioner. They have a lot of activities going on in the tribal areas. So best way is to catch hold of or have a meeting with the tribal commissioner. He is an IS officer. And with his influence, you can see that DHO can be there. So public health department people would also help you. Community-based organization like Lok Biradari Prakalp of Dr. Amte, they also can help you. Will this group enable to participate from different constituents of community? Okay, whether we can ourselves participate, that also we need to train and ourselves, okay, how we are going to interact with our community. And there are local limitations. Madam, you would not believe, we went there, nobody told us, and there was not a soul, even before a pre-visit 3 days before the camp. So where are they gone? So from that day onwards, that Mahua flower collection season. So they would go to forest to collect this moha fool. And nobody would be there in the village. So again, we had to come back. And after the 15 days, then, so that's how the time limits are. It's very difficult to maintain the time limits. Then site identification, where you are going to examine the patient. Is it accessible to by road? Is there available space? Logistics, feasibility. Then sensitization of villagers and local administrators. So there would be a pre-visit. So we 4 or 5 of us would go to that village, tell them, go around the village, meet all the people, whosoever is in the house, and tell them that, yes, this is the, tomorrow we are, or day after tomorrow we are going to come, and you be there. We are going to check your blood and we'll tell you how much is your sugar, or we are also going to see whether your bones are very strong. So you have to tell them something so that they remain in the village and they come to your examination site, because it is very difficult to examine in their homes. Most of them do not even have the beds or cots. So most of them sleep on the floors. So therefore we have to take them to some place, and privacy, of course, as I told you, is the priority. So propaganda at villages to maximize the participation. Again, have a Gram Sabha, call teachers local if there is a school, call socially active people. There would be 2 or 3 people who are active in the village. So we should call them, and so they would come. Then preparation for camp materials that we have to carry, equipment, medicine, even blood pressure apparatus, everything you have to carry. Proforma printing. Now we used to take these proforma, and sometimes if there are, like a ashram school is there, so and that school has 150 children, sometimes there is a shortage of prints. So getting additional prints also would be difficult. So these are the things, identification of logistic providers. Now, for meals for the team, from where would they come? In a village, say, there is neither hotel nor any dhaba. So we would see if there is a Bachat Gut in nearby villages. Then catch hold of that Bachat Gut and tell them that we are 40 people, please prepare some meal for us. And also we had one, sir, this thing that we used to give as an incentive for those visiting site, that some namkeen and some sweet for at least for children, given to everyone, but at least children are very happy that some sweet they are getting. So they would come, and after blood collection, we would give them that packet of sweets or something. So when you are doing the research in community, these are the things you also should keep it in mind. These are the challenges. So again, as I said, this is very interesting. This is, I don't know whether you all know, एक दवंडी पिटवणे गावात एक असा प्रकार आहे की उद्या डॉक्टर लोक येणार आहेत. सो यू तर सगळ्यांनी तिथे यावं. सो यू जस्ट हिअर टू दिस, लिसन टू दिस. So this is in their language. And that is how in the morning, about 5 o'clock, he would go around in that village. And at after every 10 houses, he would repeat this. Then pre-camp visits, very important. As I said, we must find out whether where we are going to examine, where we are going to sit, how the patients would come, where the proformas would be filled, where the blood samples would be collected. All those things are there. So collaboration with tribal commissioner for a tribal is actually very, very necessary. And I must tell you that additional tribal commissioner here in Nagpur is Mr. Ravindra Thakre, and he is an IS officer, a very, very good officer, in fact. And he was very kind to give us 16 lakhs of rupees, which we spent on the phase 1. So that's why we could go there, spend, and because no private company, how many people would give CRS funding? So that's also very difficult to get it. And so, but anyways, phase 1, we could manage with this. Now again, phase 2, phase 3, we probably would have, we are trying from various industries. So that is one thing, that get a person, get an officer who is influential. If you could get a hold of these MPs, MLAs, at least they would come and they would at least tell their workers that you have to help these people. Then DHOs, district health officer, taluka health officer, medical officer, without them, you cannot do any research in these tribal areas. At every moment, we will require their help. So at the district level itself, headquarters, you have to go twice, thrice, meet them, request them, all those things you have to do. And in that village, teachers, ASHA workers, Anganwadi workers, without them, we cannot do any research. So what are the solutions for community engagement? Then this is very interesting, village Bandh. So we would tell them on our pre-camp visit, we'll go to their houses, they meet their prominent people there and tell that, yes, we are coming after 2 days. That day, nobody should go to a field. You should remain here because we are going to come. Lot of experts are going to come. We are going to take your blood samples. We are going to tell you that what your children are suffering from any disease. And we are going to give a treatment for next 3 years, free of cost. Then they would say, okay, then if you are going to give us treatment, then we would stay. So that would call a village bandh, and then they would come for the examination. So that is one thing, how you could come. Local announcements, as I showed you, one day prior to the camps, meetings were organized by a local team there. The THO would go there, or some ASHA worker, that tomorrow they are coming, so you be there in the village. And facilities like, blood investigation, BMD. BMD was quite amusing, that you put your foot there and you get a thing. But most of the time in those remote villages, problem was electricity. So many things, we could not do that. We had to repeat, go there twice, thrice, like that. And blood investigations, now samples are collected. The most important, children would just refuse to give a sample, that we don't. So again, they have to go coax and they have to make them agree to give samples. So these are a few of the photographs here. Then step three is data collection challenge. Again, it's a challenge. Data may be incomplete or inaccurate. So you need to have a good data to publish a good paper, to come out with some research. Your data has to be good, as therefore validation is required. Now, training and standardization of data collectors, everywhere you have to train these people. It may be very difficult to obtain culturally sensitive data. Like suppose STD, sexually transmitted disease, it's very difficult to ask them. So this is very difficult then. Now what happens, suppose blood samples are hemolyzed. Now our team has to go again, that lab people. Now if they go alone, out of say 20% samples are not collected on that day, they will go on third, fourth or fifth day as it suits them or as the weather permits. So they will go and only 10% will come. Again, 10% are remaining. So again, after 3-4 days, they have to go. And go means it's not like from Nagpur to Ramtek. You have to go miles together, and that too on the bad road. So it's very difficult. All these things are very, very challenging. Then data analysis, again, lack of infrastructure, equipment, and trained personnel. Now, madam, I am talking, this particular slide is Nagpur Regional Center. There is no infrastructure, no equipment, trained personnel. They are all daily wages workers. So you can't depend on them. So data is crude. It needs cleaning and processing before analysis. The problems are there with missing variables. So again, you have to visit, do it second time. Undue delay in obtaining data from secondary sources. Now, suppose sometimes you leave the papers that some of the indicators are not filled by ASHA workers. They will say, sir, you can go today. We will fill it up and send it to you. Send it to you means when? It is so difficult. It may take just 15 days. It may take a month to get those remaining papers from that place. Correction of data discrepancies, that is important, and digital data collection tools, that also we need to have. And here, now I think when it comes to analyzing and publishing the data, it will be suitable data analysis software would be required. Probably that would be available in the university itself. Reporting challenges are there, not much comparative regional literature is available. We can't have, in discussion, we always say that here we are examining, say, from 5 to 50 months of age, but there is no other data to compare our own finding because there is not much work has been done. In competing activities make it very, very difficult to meet these deadlines because of this. So these are some of the glimpses of our project. Dr. Kanetkar, first MUHS Vice Chancellor to visit Gadchiroli village. She had come, and I must appreciate, madam had examined the patients in that camp. This is a place, sir. This side is Chhattisgarh, like this one. This is Madhya Pradesh on this side. And you see the road ending here is Maharashtra here. So MUHS is up to here. And from here is Chhattisgarh. Nobody was willing to take me there because a few days before, a suspected informant was shot dead at that place by these activist Naxalites. So even our bus driver said, sir, I am not going to come. So that Sarpanch of the village took me on the scooter and he said, no, sir, I will take you. So he took me so I could take a photograph just to tell MUHS that here is our territory ends here. So this is madam's visit at Hemalkasa. This is Dr. Mrs. Amte. She basically is an anesthetist and she used to work now. Her son, daughter, they all work there. These are some of the camps again. See, madam had examined this baby. And she has some CP, I mean congenital deformities, also cerebral palsy. And we had sent a blood sample. Even we have not yet received a report from Bombay. Maybe I think almost 7 to 8 months have gone by. So these are few, जिवती तालुक्यातील अतिदुर्गम डोंगराळ नोकेवाडा गावात ब्लॉसम उपक्रमांतर्गत आरोग्य शिबिर. So it was really, the areas are so in the far off regions. So this is Dr. Amte. This is Dr. Mrs. Amte. Madam, you all know. This is Amte's son. He is also MBBS. Daughter-in-law, she's done DGO. This is our dynamic Dr. Rao Rane sir. He had come for one camp. Thank you very much, sir. This is again this is the hospital at Lok Biradari Prakalp. This is the only place where we could stay and cover 2 villages at a time, because there would not be any other place to stay. So we could come back, stay there. Again, Dr. Amte was kind enough to give us breakfast and also provide whatever lunch, dinner, whatever time it would be. So they were of a great help. So at the end of it, do we have a hope to give them an infrastructure? A good healthcare, good infrastructure for the healthcare. Yes, I think I'm very optimistic we can do it with suitable investment, public policy and governance. Health can be affordable and accessible to all. Empowering tribal communities must be done strategically, keeping in mind their traditions and other intangible heritage touchpoints. So they have that about, they are very, their culture, their traditions, they must be respected by us by doing a research. We cannot, in our research modality, we cannot override their cultural taboos. So challenges are many, so are the solutions, but we must find one suitable solution to the tribal community. And I hope we will find a solution and we could give them a good healthcare as we are getting in urban areas. We could probably give them in tribal areas. So thank you very much, sir, for Madam giving me this opportunity and time, and thank you for patient hearing to all those who have joined. Thank you very much.
Thank you very much, sir, for your wonderful lecture on tribal area challenges. Now I request our Honorable Pro Vice Chancellor, sir, to address.
Dhanyavad, Palaskar sir. So I think there are many challenges for the tribal research, but the excellent work Dilip Gode and his team has done in the tribal areas is remarkable. And we have also conducted 45 camps in different areas of the Maharashtra. In that, we found difficulties in Kinwat area, where there is such problems of main problems were of language. Second was of inferiority complex within the people. When we started collecting the data from them, we were not able to collect the data of moving population, because one day they are staying here and another day they are moving to their another places. So in that regions also we could reach to them for collecting the data. We have access much of the people in the remote areas also, where we found the problem of nutrition. That is, most of the people are having lack of food. So the resources we have to develop there was whatever the available food we have to conduct there, whatever the food preparation we can do there. So according to Asam and Ayurveda, in Ayurveda there are the few products like Shatavari, Ashwagandha. Then from that we prepare an ambil or sattu. And also the Nagli and Bari, that the bhakri preparation is done, so to prevent the anemia in them. Also, they eat most probably the fish food. That is also helpful to develop the protein which can be gained from them. So again, we found challenges of lack of understanding the non-verbal communications in them. also the acceptance of cultural values, also the resistance from the social workers who was present in there. Also, the most problem was what lack of accommodation, because we stayed there for 30 days and the area was not having any hotels and other things. So we stayed in our tent houses, and whatever the resources we are available, we have taken the food packets with us also. So it is very difficult to survive there in such conditions, and the scanty peoples are there in scatteredly divided in dense forests. So it is also a challenge to access them. Without any guide, we can't reach to them. So this is an very difficult task, and I will thanks to Gode and all the teams who reached to the Gadchiroli areas in the dense forests also, and also in the Naxalite areas where we could reach. Thank you, sir, for your valuable support.
Thank you, sir. Now, at the outset, I would like to thank Dr. Dilip Gode, sir, who is the chair professor in tribal research. Sir, you have given a great insight of what are the real challenges on the ground when you are to conduct research in tribal areas. Thank you very much for sparing your valuable time, sir. Thank you very much. I would like to thank Honorable Vice Chancellor Dr. Madhuri Kanetkar, Madam, for her dynamic and visionary leadership, through which we are conducting this particular series of Dr. Daulat Rao Aher Memorial Guest Lecture Series to give him a tribute. So thank you very much, Madam, for giving this opportunity. Respected Pro VC Sir, Dr. Milind Nikum, who always encourages us and keeps us motivated all through. At the same time, I would like to thank our respected Registrar Sir for providing us all administrative support. I would like to thank our Controller of Examination, Dr. Sandeep Kadu Sir, for giving valuable inputs, and our Finance Officer, Shri Narhari Kalaskar Sir, for supporting us financially. Our Dean Academics, Dr. Mrunal Patil Madam, who is constantly guiding us and encouraging us and keeps us motivated all through. So thank you very much, Madam. At the same time, I would like to thank all the principals, faculty members, students of all affiliated colleges, those who have joined this lecture today. I would like to thank all HODs of university, administrative wing as well as academic wing. I would like to thank faculty and staff of MUHS. At the same time, I would like to thank IT technical team for organizing this lecture online. And this lecture link will be valid and will be kept live. So those who have missed this lecture, they can revisit this by clicking the link. I would like to make one announcement. After this, there is at 4 o'clock, there is another lecture by our chair professor, Dr. Anuradha Chaugale Madam, which is organized by GIBN Regional Center Pune. So please do join for that lecture. It is also equally informative as Dr. Gode's lecture was. So I once again thank you all of you. Thank you.
Thank you, sir.
Thank you very much, sir.
Thank you. Yes.